Let's apply everything we just learned with a case.
We're seeing a 55-year-old post-menopausal female with fatigue.
Okay, so our initial differential diagnosis is going to be pretty broad to start, but we still want to think of the more common possibilities in older females. Things like hypothyroidism, perhaps menopausal symptoms. Is it anemia, type 2 diabetes? Cancers that are common in older females, like cervical, breast, colorectal cancer, maybe even uterine cancer, mental health conditions, substance use or medication side effects, or perhaps sleep disturbance or sleep apnea. So we go on to perform the history and we learn that she is in menopause for the last year or so. She also has new onset constipation, hasn't had colorectal cancer screening, and her father had colon cancer at age 50. But she's up to date on cervical cancer screening, breast cancer screening. She's not having any abnormal uterine bleeding, and mental health is pretty well. So now our revised differential diagnosis is looking at the most likely conditions, but also the red flag possibility of colorectal cancer that we wouldn't want to miss. So we do want to perform further testing for things like hypothyroidism, colorectal cancer, and diabetes because we know it's fairly common in older adults. So we go on to order more tests like a CBC to screen for anemia secondary to colorectal cancer, a colonoscopy, of course, a TSH to look for hypothyroidism, and a hemoglobin A1C to test that possibility of diabetes. So results reveal a normal A1C, CBC, and colonoscopy, which are all reassuring findings, but the TSH is fairly elevated. So that cinches the most likely diagnosis of hypothyroidism. We've landed that conclusion because of the history, the lab results, and ruling out the dangerous things like colorectal cancer. So this brings us back to the principle of Occam's razor. We want to find the simplest, most likely explanation for the patient's symptoms, which in this case is hypothyroidism. So now we can go on and treat with medication for hypothyroidism. But she actually comes back a couple months later and she has still pretty severe fatigue, and now it has developed purplish skin patches. So, okay, we have to go back and now revise our differential because her symptoms aren't improving as expected. Now is the time to think of perhaps less common or rare diseases like Addison's disease. Does she have Cushing's disease or another type of autoimmune disease? Maybe something infectious. We're thinking about those less common causes. And that hones in on the theory behind Hickham's dictum. Patients can have multiple diseases at once. So we go on to do a few more tests and we learn that she has low blood pressure on exam and lab results reveal low sodium. So now we're thinking, okay, the most likely diagnosis might be Addison's disease at this point, but she also has hypothyroidism. But now I should be probably thinking even deeper because she has two autoimmune conditions. She has hypothyroidism and Addison's disease. So does she have some rare underlying cause of these diseases, like a polyglandular autoimmune syndrome?
And yes, I had to look that up.
Which are rare disorders where the immune system attacks multiple endocrine glands, causing them to fail. So when these new diagnoses pop up unexpectedly in a patient, a lot of the time, myself included, I'll think back and say, wow, that should have been obvious. How did I miss that condition? But in this case example, we can see that Addison's disease initially wasn't an obvious diagnosis. There wasn't the low blood pressure. There wasn't the purplish patches on her skin. But we can see that that disease evolved over time and eventually became more obvious to us. I also want to highlight the point that based on our initial list of differential diagnoses, we didn't necessarily have to test for everything, say sleep apnea. We didn't go ahead and order a sleep study for this patient because we had already landed on that most likely possibility of hypothyroidism. So now I want to bring up a final point to round this all off. We know that a diagnosis is a fluid moving target. It's contextual, it's related to our role in the patient's care. So a diagnosis you make in your setting may not actually be helpful for another provider looking after that patient in a different setting or role. For example, in primary care, if I diagnose breast cancer in a patient, that's clinically meaningful. It triggers a referral, let's say, to an oncologist. We don't have to have more diagnostic detail in that case. But for an oncologist, that same diagnosis of breast cancer is far too broad and actually isn't very helpful. They need the biopsy results, the receptor status like HER2 positivity, the exact subtype to guide their treatment. It's the same disease, but different diagnostic depth. So, no matter where you are in your training, just starting, early, mid, or late career, we can always find ways to refine and improve our diagnostic approach. But this requires ongoing growth of our internal knowledge bank of disease, feedback, so knowing our patient outcomes so we can reflect and refine our approach, deliberate practice, so knowing what practice gaps we need to fill, not only knowledge gaps, but also gaps in how we think and approach problem solving. And we can use strategies to cue our memory bank of diseases to guide that overall assessment with different diagnostic frameworks like the systems, mechanisms, anatomic, and mnemonic or checklist approach. We'll get into all of these diagnostic approaches and pearls later in the course.